So just really tell you a little bit about the collaborative. I work for one of the 6 partners, MIA, and the other partners are Innovation Agency Northwest Coast, NHS Northwest Leadership Academy, Northwest ADAS, Northwest Employers, and Aqua. And the collaborative combine their unique specialisms, deliver the diverse programme of events across the year, across sector as well. So you were sharing ideas and information for senior leaders across the Northwest. Okay, just before I hand over to Richard, who's going to sort of speak and chair today's events, just wanted to say a little bit about this event. The annual health check is one of our longest running events and probably one of the most popular. And in particular, I'd like to thank Anita and Chris for their continued support over many years. Every year we seem to introduce this event by saying this year it seems to be more important than ever, but it really does feel like that this year. You know, we've had the pandemic, Omicron, and that's had a significant impact across the Northwest, across the public sector, and particularly the clients that MIA work with. We've got the expectations in terms of elective recovery, and really high, but also we've got to deal with the backlog in terms of both in the acute and the community sectors. The healthcare bill is going to provide some significant opportunities across the public sector to work collaboratively together, but also it's going to provide some significant challenges as well. The public sector, as we all know, is financially challenged, and we're going to hear a lot more about that during today's presentations. And then finally, yesterday in the Health Service Journal, we saw that the overall rating for satisfaction in the NHS has plummeted to an a low since 1997. So all in all, very challenging times for the public sector, and again, really does show the real benefit of today's events and to highlight the challenges ahead. So this is the programme. I'll not sort of take you through that in detail. You'll have seen that already, and I'll just hand over to Richard now, who'll start the first session. Thanks, Richard.
Steve, thank you very much, and good morning, everyone. So my name is Richard Stubbs. I'm the Chief Executive of the Yorkshire and Humber Academic Health Science Network and also the Vice Chair of the National A2N Network. I'm delighted, truly delighted to be asked back to help chair this session. As Steve said, I'm really looking forward as well to hearing from the wisdom of our speakers. And as always, there's some amazing speakers we're going to hear from today. I shall be listening intently and then passing off their knowledge as my own for the next 12 months until the next session. Unfortunately for me, I think the cost of my entry is that I also have to do a little bit. That may be unfortunate for you as well. But I'm going to try and set the scene and talk unashamedly with a northern focus. So I'm just going to spend the next 15 minutes or so trying to set that scene, talk about health inequalities, why health inequalities has rightly risen to the top of our collective agendas. I'm going to talk about the impact of the pandemic on health inequalities, and then start to draw a link from health inequalities to the levelling up health and wealth aspect of policy, what it means for us in health, what levelling up means for us in health, but also what we can do within health to support the levelling up agenda. But I'm going to start, as I say, with a little bit around, I suppose, just taking a step back and looking backwards before we start to look forwards. So as everyone knows, the impact of inequalities across the country has been acknowledged for some time, long before the outset of the COVID-19 pandemic. And that was very prevalent in the government's ambition to level up regions and the planned changes to the Treasury Green Book. Those of you might know, if you're in policy, were outlined long before the pandemic. The north of England, as most of us, I think, will know, is a prime example of the inequalities that exist in the UK. So, for example, in my patch, Yorkshire and Humber, we've got the third lowest life expectancy for men and women, and the second highest levels of obesity in England. And on average, in Yorkshire and Humber, women live 21 years of their life with ill health. Some of you in health will know about the work of Sir Michael Marmot. His latest report in 2020 stated that time spent in poor health is increasing in men and women in the most deprived areas of England. And unsurprisingly, the north-south health gap, that's the difference in life expectancy between the least and the most deprived, is increasing and has increased. I think that the key point, though, is that the health of the population is not just a matter of how well the health service is funded and functions, although, of course, that's hugely important. Health is closely linked to the conditions in which people are born, grow, live, work, and age, and the inequalities in power, money, and resources, or the so-called social determinants of health. So to put it quite simply, it means that in order for people to live healthy lives, it's not just about ensuring they have access to healthcare services. It's about ensuring that they have the ability to make healthy life choices from childhood, something which is influenced by things such as the area that they live, access to outdoor facilities, and of course their household income. Next slide, please. Depressingly, but obviously, the pandemic only further exacerbated and accelerated those challenges that were already apparent before the pandemic, particularly across the north. We're all familiar with the concept of the pandemic disproportionality impacting some areas of the country. So, for example, during the first year of the pandemic, people living in the north had a 17% higher mortality rate due to COVID-19 than those in the rest of England. So the pandemic absolutely laid bare the impact of inequalities upon the population, the poorest parts of the country, due to the link between health and wealth, which are also the areas suffering with the greatest ill health, have the worst mortality rates throughout the pandemic. And the economic impact of that increased mortality will continue to be felt for some time. And across the north, we would expect it to cost our northern economy in excess of £6.86 billion. So it's absolutely vital that we continue to firmly tackle this challenge now before the health and the economy across the north continues to fall. Next slide, please. So it's a bleak picture, potentially, about how we've been negatively impacted, but perhaps also it's an opportunity to reset our thinking about our health and the economy, how it links, and how we can take steps forward to begin tackling those challenges that we face. We've seen, obviously, health inequalities increase throughout the pandemic. We've seen life expectancy fall. We've seen time lived in poor health increase, which means also that productivity and economic prosperity of our regions in the north is falling. So there's a cyclic negative impact on people's health. I mentioned about the Sir Michael Marmot report, which showed the widening health inequalities and the regional disparities in life expectancy. The need to get it right now is more important than ever. So the pandemic has presented us, I think, with a real opportunity to totally affect structural and long-term changes in the way that we focus on both health and the economy, and how we can firmly begin tackling long-standing inequalities. But to do this, we need to build upon this increased interest, current focus on population health and inequalities, as well as the increase in joint working, which we saw brought about by the pandemic, both within society, but also across political circles. Next slide, please. So obviously, I won't go into detail on this slide, but the impact has had a significant impact on our personal prosperity in the northern economy as a whole. Productivity in the north is lower than the rest of England. A key reason for that is that health is also worse in the north than the rest of England. And we know that long-term health conditions and comorbidities, which is obviously common across the north, lead to further economic inactivity. We also know, through some great work by the Northern Health Science Alliance, that spells of ill health also increase the risk of job loss and then often lead to lower wages when people return to health. So there is a poverty trap through our increase of ill health across the north. Next slide, please. But the pandemic, as I mentioned, it demonstrated the system's ability, the country's ability really to work collaboratively and to jointly make widespread change and to think innovatively about solutions to tackle the challenges that we were facing. So we now need to build upon that appetite for joint working and appetite for innovation to further tackle the inequality challenge within our region. We need to take the industry that we focused on tackling COVID and now point that partnership working and sense of togetherness and policy joining towards the inequality agenda. But we've probably got a time-limited opportunity, in my opinion, to build upon that culture, that mindset, that way of working before our natural tendency to return to pre-pandemic positions take precedent. I think specifically in the NHS, it's about how do we maintain and sustain the positive cultural conditions that allowed us to empower our frontline staff to make the right decisions to be able to change and transform the way that we can deliver care we don't want people to continually exist in crisis mode. We don't want change and transformation to only happen because of the advent of something like a pandemic. But within that, there's a lot of learning, there's a lot of research that we've done to understand what are those conditions for change that will allow us to sustain some of that risk appetite that we saw, the ability to think differently, act differently, be empowered to do differently. And how did leadership across the NHS and the wider public sector enable that to happen? And I think that's a real interesting question for us to think about as we now turn towards inequalities, and also within health as we turn towards the elective backlog. Next slide, please. So reasons to be cheerful. So despite all the challenges that we face in the north of England, we actually do have a huge and growing health and life sciences sector. Anybody who was watching Parliament TV, and I'm not sure why you would be, but anybody who was watching Parliament TV 2 days ago would have seen George Freeman talk fantastically about the fantastic health and research assets that we have in South Yorkshire, for example. And there are other fantastic assets across the entire north of England. So the sector continues to positively impact on both the health and the wealth of our population directly, but also the economy nationally by our contributions to GDP and providing high value jobs, high value employment. We actually, obviously through a growing health and life sciences sector, positively impacts on the health of the wider population as well as overseas as well. Next slide, please. So as you can see here, and this is just a snapshot, over 800 life sciences businesses are in the north, and actually we expect that number to be much greater, because that number does not capture the wealth of businesses who aren't actually rooted in health and life sciences but regularly work within our sector. So for example, digital companies aren't captured in that metric. Our life sciences in the north employ almost 25,000 people, representing almost 30% of the national employment in the sector. And 25% of the UK's total employment in digital health, which is such a growing and important sector, are based in the north. Next slide, please. So as we start to look ahead and start to think, so how do we take advantage of some of the opportunities that are here, some of the increased spotlight that has been shone on inequalities in particular as a result of the pandemic? I just wanted to start looking ahead to that future through a slightly wider lens. So let's consider what's happening in the wider landscape, the policy landscape, which is likely to impact and support the work that we're already engaged in and keen to start to further tackle that prevalence and impact of health inequalities. So I think obviously within healthcare, you start with the imminent changes to ICS, ICB structures, integrated care systems, integrated care boards for those people outside healthcare who are with us today. That's going to provide a more effective mechanism for genuine place-based working, and a huge opportunity within that to refocus priorities. So how do you move to a preventative health model? How do you have a focus on population health at place level? How do you start to look out and not up from a health leadership perspective to understand the place-based leadership needed to tackle those wider social determinants of health? And how do you start to create genuine partnerships within your place? And place can mean different things to different people, that are going to start to have real impacts, not just on the sickness of society, but that prevention wellness aspect of our society. Similarly, the recently published operational planning guidance has a strong health inequalities theme, setting out the NHS's intent for ICBs and for other constituent organisations to focus their work on tackling inequalities. We know that we're just about to refresh the long-term plan. I'm sure Chris will pick that up later. And I think the long-term plan, again, the refresh will absolutely start to drill down on the priorities that the centre believes that the system needs to tackle. And I think absolutely health inequalities will be written throughout that document as the guiding principle to determine how we prioritise our day-to-day activity within the NHS. And then slightly outside of health, but very related to it, the Levelling Up white paper outlines the government's commitment to this important agenda and will absolutely be a supporting factor. I mentioned already, but the pandemic brought about that increase in collaboration at place-based level. And that's not just collaboration within the public sector. Certainly on the ground here in the teeth of the pandemic, we saw a huge collaboration start to be fostered between the public and private sector. I think the NHS, other public sector organisations, getting much more comfortable to have better strategic partnerships with their supply chain, but also actually building new bridges, new relationships with other parts of the private sector who hadn't really understood the contribution that they could make to health and hadn't really understood where the front door is into a healthcare supportive delivery conversation. And we saw a lot of that start to be fostered through necessity during the pandemic. But as I mentioned before, it's how do you sustain some of those conditions that have allowed us to think differently and work differently in the future as we move towards a state of living with COVID rather than being in the teeth of the pandemic. And then I'm going to touch upon this in a bit, but the role of anchor institutions. I mean, it was highlighted during the pandemic, and many anchor institutions played a key civic duty, bringing about a rethinking of their roles within their region. And many of those organisations are still a huge and relatively untapped resource in terms of what they can do to support tackling inequalities. I think also looking to the future, imminent future really, but we're looking forward to the health disparities white paper being released, and then considering how our work can support the commitments and the intentions that will be within that paper. And we continue, obviously, I think, to be very close to the levelling up agenda, which I think is hugely important, not just for our northern economy, but also, as I mentioned, because of that link between health and wealth, levelling up is vital to our ability to reduce the ill health disparities between the north and the south through providing better jobs, which then gives people access to housing, skills, education, and all the things that we know are truly responsible for improving people's health. Next slide, please. So I've just mentioned anchor institutions. So just to drill down on that a little bit further, you're all hopefully probably aware that anchor institutions are typically big organisations rooted in a place, local councils, universities, colleges, hospitals, housing associations, or sometimes large businesses. And owing to their size, they are inherently influencers at that place level. However, many non-public facing anchor institutions don't perhaps realise yet the influence that they have upon a particular area. But as we would probably understand, they play a hugely vital role in recruitment, paying conditions, training and development, workforce well-being, local supply chains, management of buildings and infrastructure. So with that in mind, and considering previous conversations about the links between those wider determinants of health and the economy, it's easy to see how much influence one anchor institution can have upon the health and the wealth of its population and the place in which they are based. So one of our challenges, and this isn't a challenge that's specific to health, it's a societal challenge, but one of the challenges is to get those anchor institutions, public and private, to recognise their civic role and the potential influence that they have at place level, and therefore to become enablers and champions for driving inclusive economic growth across the place in which they operate. And that could be by investing in health and wellbeing initiatives for their workforce, which is something we're talking about quite intensely actually here in South Yorkshire, and or to strengthen their local supply chains for goods and services and enable the trickle-down effect by securing local jobs through better local supply chain decisions. And in addition to the core activity of delivering public-facing health and wellbeing services, NHS estates, NHS sites, secondary care hospitals, for example, have a huge role to play as anchor institutions and as influencers as much as any other anchor within a place. So it's really important that NHS anchors recognise those linkages between their public-facing core services and their civic duties as an anchor, and seek to align the two agendas wherever possible to maximise impact. Next slide, please. So just to, I suppose, get a bit closer to home, or maybe do a little plug, but in Yorkshire and Humber, and I apologise for being on the other side of the Pennines today, but in Yorkshire and Humber, health inequalities has been a big topic for us for some time. I probably spoke about this last year, but in 2019, alongside our friends in the NHS Confederation and Yorkshire Universities, we launched our Why Health for Growth programme. And that was really about a campaign that I sought to create about how do you bring health health leadership, health delivery leadership, particularly through the NHS, to that table of economic and inclusive growth? And how do you get the NHS to really start to understand those intrinsic links between health and wealth, and crucially, I guess, their impact upon it? So we had 2 events to promote that work amongst senior leaders, and then we published our work as this document you can see there, Levelling Up Yorkshire and Humber Health as the New Wealth Post-COVID, which focused on the impact of the pandemic on our region's health and economy, but also the role of health in helping us to drive forward those economic challenges that we face. And then there was a series of events aimed at bringing senior leaders together from across the region to raise awareness and to promote joint working to tackle those challenges. I think crucially what I'd say is, although of course I've based my work in Yorkshire, I think the both the content and the outputs of that report are absolutely attributable or relevant to other regions across the north, as you would expect. And if you are sat there thinking about how do I start to understand how my role delivering public sector services, particularly in health, has a relation to levelling up, then I would humbly offer to take a look at our work and as maybe a guide into that topic. This year we had very recently in Liverpool the Convention for the North, which was all about the region's health and life sciences sector, and understanding that as we think about levelling up, this is both an ask from the North, but it's also an offer to the rest of the country. And when it comes to the northern assets around our health and life sciences sector, there's truly an opportunity through greater investment from government to make the North a genuine offer to the rest of UK PLC in terms of our contribution to GDP, but also a genuine offer in terms of how the innovation, transformation and life sciences know-how that would come out of accelerating this sector would then be a boon and a bonus and an offer to the rest of the country in terms of picking up the nation's health, not just health in the north. And then also we did a lot of work during the pandemic on reset. So that was all about the role that the national and the regional healthcare systems have to play in tackling inequalities and improving population health across the region, and that's still available online as well. So in conclusion from me, when we think about inequalities, when we think about levelling up, and when we think about the pandemic, the North, as I've mentioned, has historically come out of the blocks hampered through the disparities that we know have already existed, and the pandemic's only made that worse. However, within that, there is a huge opportunity to use the levelling up agenda to indicate to government why the North, more than any other place in the UK, is ripe for investment that's going to bring us high value jobs, investment that's going to empower or power up our health and life sciences sector. But those jobs that in with investment is also going to increase the health of our northern population in a way that is absolutely morally the right thing to do, given the disparities that existed across decades between the north and the south. So it's an ask as much, well, it's an offer rather, as much as it's an ask of government. So we have a long-standing reputation with our clusters of activity and assets and excellence within health and life sciences. And there's now a critical mass to really strengthen the UK's offering in this sector, tackle levelling up, support place-based working to address those challenges and opportunities within research, skills and innovation. We've actually got 4 globally important areas of opportunity where our research excellence and innovation capacity is aligned to market opportunities within that sector. So advanced therapies, infectious diseases, diagnostics and medtech, and data and artificial intelligence are our 4 globally important areas of research and innovation across the north, all of which are hugely important, not just to the health and security of this country, but on a global level as well. According to the Office for Life Sciences, in the north, we employ nearly 24,000 people across 800 businesses, which is almost 30% of the national employment in the health and life sciences sector, 25% of our UK's total employment in digital health, and 24% of the medical technologies sector is based in the north. And as I mentioned before, those numbers are much greater when you factor in those companies who are working in the health agenda, but not necessarily considering themselves to be healthcare companies directly. So that workforce, that number of private sector organisations is a key contributor to our economy. The Northern Life Sciences economy is estimated to be almost £14 billion in size and home to 21% of the UK's total life sciences workforce. And it's really important to understand that that cluster of activity isn't constrained to the private sector. So the North is home to a wealth of NHS and academic anchor institutions, all of which contribute significantly to our Northern region's research and development activity. So for example, across the North, we account for approximately 22% of all UK patent applications in the medical and biological fields. So the future is bright for us in the North. I think my conclusion is that levelling up is as much about health as it is about wealth. We need to use the opportunities of the integrated care boards, integrated care systems and places to recognise that we need a cross-public sector, cross-societal mission to level up our health by levelling up our economy. We are not going to achieve the kind of health outputs that we want across the North without also having a significant increase in the economic aspects of or opportunities within our region. And that includes skills, education, housing, transport, as well as jobs. So in health, let's not just think about our delivery of healthcare services. Let's think about how we operate as place-based leaders. Let's look out as well as looking up. And let's think about how the economy has a real opportunity to improve our health for the future. So that's all from me. Thank you. I think there's one more slide. And luckily, as chair, I don't have to interview myself, which means that I can hand straight over to our next speaker. So I'm going to introduce John. So John is Director of Adult Services with Oxfordshire County Council, Director of Adult Services with Oxfordshire County Council between 2007 and 2016. But since 2017, John has worked for the Local Government Association as a National Care and Health Improvement Advisor, advising local authorities on managing financial pressures and risks within adult social care. In the last year, he has spent time advising on financial issues arising from COVID-19, the continuing financial pressures facing adult social care, as well as the financial issues that arise from the proposals for adult social care reform. John will explore the financial issues arising from COVID-19 and hopefully we'll have some questions for John at the end. So please do use chat to drop your questions in. The team will be looking through the Q&A as John goes on, and hopefully we'll have time at the end in about half an hour or so to ask John your questions. John, over to you.
Thank you very much, Richard. I should start in terms of my background is before I was Director of Adult Social Services in Oxfordshire, I was the Director of Resources there. So I've got a relatively unusual background where I've been both a Chief Finance Officer and a Director of Adult Social Services in local government. Good morning, everybody. I'm afraid I feel this is rather a bleak presentation. Richard had some very positive comments to say about what was happening in the North in response to the health inequalities agenda. It's difficult to be positive about what I'm going to say, I'm afraid. And if I move on to the next slide, really, the starting place that adult social care was in before the pandemic was not a good one. And that reflected very much what had happened to local government. Local government was very much suffered much more significant cuts in funding than other parts of the public sector. And it's probably worth lingering on a little bit on that in the context of what Richard just said about the social determinants of ill health. The fact is, the contribution that local government plays to that is not just about adult social care and public health, but it's actually about a wide range of local government services which have been significantly cut in recent years. And I'll show you the evidence for that. Adult social care faces very similar pressures to health of demographic pressures, increasing demand, but there's also been a particular issue about inflation, and I need to linger a little bit on that because that's probably the most acute pressure there is around at the moment. I do want to make an assertion though, probably one of the more positive things I'm going to say is that despite that, there's pretty clear evidence that despite all the pressures on adult social care, quality has improved. But the threats are huge because there are major workforce issues, many of which will be similar to health NHS colleagues. But there's also a huge issue which we must not ignore across health and social care about the pressure on paid carers. My main messages are going to be about that underlying position because that is so big and so immense, it's enormous. But broadly what's happened is COVID's added to those pressures and it will continue to have an impact going forward. But we've then got a huge reform agenda, which could be positive, but actually, unfortunately, is almost certainly going to add to the financial pressures facing adult social care. So I'm moving to the next slide and then the one after. So just looking, these are some slides. If anybody came to this session in 2019, when I came up and spoke personally in the old days when we didn't do stuff like this, I used the next 2 or 3 slides then, and it's really just to provide, particularly for people who don't work in local government, just some understanding about where adult social care fits. Now, this is a slide, and some of these early slides come from a very useful National Audit Office publication, which is slightly old now, but has a very good independent view about local government and adult social care. So this slide goes from that publication. It's called Adult Social Care, Focus on Adult Social Care, something like that. If people want information, I'm happy to provide that afterwards. What this does is just show the importance of the size of adult social care amongst local authority budgets. So on the left-hand side, relatively small print, I apologise if anybody's got accessibility issues, but the key thing is the big tower on the left-hand side is adult social care. The next biggest side is children's social care. And then the rest are pretty small, actually, in terms of the position. This is the position in 2016-17. If anything, those numbers relative to the others will have got bigger since then. And then move on to the next slide. This is a slide the Local Government Association uses, and what it tries to do is illustrate broadly what should have happened for adult social care spending, and that's the top line going up. I'm slightly colourblind, but I read that as yellow. It's quite light. Hopefully that other people have seen it a similar way. If you compare that to the very bottom slide, which I would have said is blue, but I can see people saying it might be black or possibly dark green, there's a big difference, and that is the actual underlying level of general resources that local government got over that period. That wasn't, adult social care spending has still managed to increase, and that's the next line down from the top. So the yellow one's how it should have gone up. Adult social care actually broadly went up in line with the red line. The difference is the savings that adult social care have made, and that is a lot of money, is that bit there. It was able to do that despite the resources not falling so much because of 3 things, really. Firstly, the fact is other services were cut to help fund spending in both adult social care and children's. There was money transferred across from the NHS during that period, and then more recently there's been ring-marked and earmarked funds that have been made available. But that's quite a bleak picture, and I think is very useful in understanding broadly the overall pressures on local government, how local governments responded, but also the fact that still led to significant cuts in adult social care. So we'll move on to the next slide. This again is from the NAO document, Adult Social Care at a Glance. The key thing here is local authority spending on adult social care, this is in cash terms, fell by 3%. In contrast, and I'll leave you to read the specific examples yourself, but the fact is many other local government services were spending fell enormously, by more than half in the case of planning and development, nearly half on housing services, which I think should be an issue for all of us because we know housing is a key social determinant of health, and then other issues. And it's probably worth saying for many local electors, as we approach an election coming up, they will be very focused on issues like highways and transport and cultural and related services. And then if we move on to the next slide, I want to now focus a little bit more. So that's a little bit of a historic view, and I want to focus a little bit about what are the immediate pressures around now, and which will be there, frankly, for the foreseeable future. Demographic pressures, I think, is pretty easy to understand. People focus very much on the fact we've got an aging society. In fact, of course, for adult social care, it's not just about more older people. More older people on its own doesn't necessarily lead to increased demand. It's actually the extent to which people have disabilities, and that's obviously a feature of older age. But it's also the case we have more younger people with more complex disabilities now, and a lot of that's attributed to the NHS. That when I was born in the late 50s, people with a significant learning disability or physical disability were unlikely to live to become an adult. That's been transformed, which is really great progress. But actually what we're now seeing is those people need a lot of support with their personal care needs, and that support is becoming more needs to be developed. And what we've seen, the Association of Directors of Adult Social Services, ADAS, do a national survey every year, and they ask local authority directors to report how much is to quantify the demographic pressure locally. We've got data going back to at least 2010 on that. Throughout most of the last decade, the pressure was around about 3% of net spending on adult social care, of which more than half was younger adults rather than older people. That what then happened in the last couple of years, that pressure has steadily grown to 4.1% of the net spending, and that reflects that increased acuity or complexity of need. And I think it's very unrealistic, given the trend has been steady and then increased, to assume any reduction of that in either the next couple of years or, frankly, in the foreseeable future. If I can then move on to the next slide, this focuses on inflation, and I mentioned this was becoming a particularly significant issue. Since 2016, adult social care providers have faced very significant cost increases, and the main driver of that was the introduction of the national living wage, which I think all of us would welcome, because it has done something about increasing the pay of lower paid workers. But the fact is, nearly all adult social care is delivered by people who are paid at the national living wage. So if there's a significant increase in the national living wage, as there has been in most years, then actually that is a significant cost pressure on providers. Their cost profile is almost entirely labour. You're probably talking about 70% of their costs are driven by labour, and therefore directly affected by the increase in the national living wage. This year, tomorrow, well, actually, I think it's the 11th of April, it comes in as the new increase. The national living wage is going up by 6.6%. If you add on the fact that adult social care providers will also need to pay the health and social care levy as an employer, and the fact the significant non-wage inflation around the moment, then their overall cost pressures next year are going to be at least 6%, and they're going to be looking to local authorities increasing their fees and the amount they pay for each care package per hour or per week to go up by at least 6%. Potentially that could be much more in areas where there are significant problems with recruiting and retaining workers. The projecting forward to 23-24, on an assumption that the national living wage is likely to go up by a further 5% in a year's time, which would be consistent with the government's manifesto pledges, then I think we're talking about another 4.5% roughly increase in fees in a year's time. So that's huge financial pressure, and that's separate to the pressure there is from demography. If we move on to the next slide, please. One of the underlying pressures before COVID was that care providers have been arguing, and you'll be pretty familiar with this argument, that local authority fees were not sufficiently high to reflect the cost of providing care. Now, our position in local government would be, well, we don't necessarily agree with all their arguments or all their calculations, but we do believe there's some substance to this issue. And in September 2020, the Institute of Fiscal Studies did some work for the Government Association, which suggests that to address this particular issue, at least £1.5 billion is required to address this issue and avoid serious risk to providers. The problem is if providers aren't paid enough, they could go bust, or they could decide to stop having contracts with their local authority. That gap is separate. It's really important you understand the 6% increase doesn't address that. All it does is leave a steady standing rate at the end of it. There's still a £1.5 billion gap. The government's come up with this concept of a fair cost of care, which local authorities are working on at the moment, and I'll say more about later on. That should help that, but there's a real question about whether that has been properly resourced by the government. I did say that despite this really difficult financial environment, there is evidence that quality has continued to increase. And this slide here shows the proportion of care services which have been rated as outstanding or good by the Care Quality Commission. You'll be well aware that nearly all of social care is provided by organisations who have to be registered with CQC, and they're inspected. And I think what we've got here is, so this is the inspector's view about the quality of care that is provided by registered care providers. And what you've got there is not many authorities who are providers who are outstanding, but actually a steady increase. In the case of those who are good, a consistently high figure, but it's gone up over that period. Similarly, the numbers requiring improvement has gone down. And the numbers that are inadequate have gone down, and actually very few in number. So I think we would contend that despite the pressures, providers, those providing services and those commissioning services, local authority, have worked really well together to try and make sure that the reduced resources is used in the most effective way and to provide the best possible services. And that's not to say there aren't gaps and there aren't things going wrong, but overall the position is actually much more positive than I think people necessarily recognise. If I move on to the next slide, please. Workforce, quite a lot on this slide, and I think this reflects the fact this is probably our biggest problem. I mean, some basic facts. There are more people working in social care than there are in the NHS. That's 1.65 million people compared to 1.5 million. 6% of everyone in employment works in the social care sector. If you work out the total direct, indirect and induced value of the adult social care sector in the UK, it's estimated to be about 2.6 million jobs. 1.8 million full-time equivalents, and that's worth about £46 billion to the economy. It's actually quite an important part of the economic sector, and that will be true in all local authority areas. On pay though, and I've got another slide which really brings this out, the average pay is low. You know, it's £8.87, that's 24 pence less below the rate paid in most UK supermarkets. 3/4 of everyone in the care sector is paid the minimum wage of £8.91, and 24 of them, a quarter of the people working, are on 0-hour contracts where they have no guarantee about the income that's going to come in. There are an estimated 6.5 million people who are providing unpaid care to 1.3 million people, and on average they're providing 50 hours of care per week per carer. There is a specific issue about COVID and its impact in terms of the numbers of workers within social care who died. The figures are there. You can see in the case of men, 79 deaths per 100,000 social care workers compared to just over 31 for workers in general. And amongst women, it was 36 compared to under 17 for the general working population. So that's been a particularly difficult issue, and undoubtedly will have impacted on issues about morale and recruitment and retention. Currently, there are 112,000 vacancies in the sector, over 7% of the workforce, and that includes 11% of care home managers. There's details around which suggest there's particular problems with things like the recruitment of nurses in nursing homes. And turnover is a horrifying 30% per year, which compared to the 12% figure for the NHS. So that is a particularly bleak picture and is a particularly problematical area, and some of it will require significant resources to address that. If we move on to the next slide, I did mention a little bit of comparison. The slide on the left-hand side shows the average care worker pay compared to some of a low-wage occupations such as kitchen and catering assistants, launderers, dry cleaners, cleaners and domestics, sales and retail assistants, and hairdressing and barbers. And what you can see there is that the slide on the right-hand side shows the comparative position in 2019-20, and you can see there, whereas care workers were paid better than all 5 groups in 2012-13, they were paid less well than cleaners and domestics and sales and retail assistants in 2019-20. I think there's very, very strong evidence that that will have got worse in the last 2 or 3 years, especially in terms of as we've moved economically out of the impact of COVID, and the demand for workers has gone up across the sector. And somebody just put a comment in to say shocking figures, and I strongly agree with that. I do want to say a little bit about unpaid carers. I mean, many people on this call at some point in time will have been an unpaid carer. I have. It is a huge pressure on individuals, even if you actually know what you're doing and you know your way around the system, I would say. It's incredible pressure thing, and it does have an impact on people's health. So there's a survey done in 2019, 25% of unpaid carers reported bad or bad physical health, and nearly 30%, 29% bad or very bad mental health. 81% of all paid carers reported having felt lonely or isolated. There's a 21% increased risk of stroke for spousal unpaid carers. That's an interesting social determinant of health there. We've got an issue about the prevalence of what's called sandwich carers. I'm not quite sure whether I quite like that phrase, but I think it does explain what it is, which is where you've got somebody, say, in middle age, and by that I'm saying somebody maybe 40 plus, who has both young children and at the same time is caring for older people. And there's 2.4 million people in the UK in that category. And unpaid caring has increased since COVID-19. I'll pick up a little bit more of that when I talk about COVID specifically. But Carers UK said there's been 4.5 million new unpaid carers since the pandemic. And they also estimate the value of unpaid care at £111 billion, which is probably about 2/3 of the, well, maybe more than 2/3 now of the budget of the NHS specifically. So I think just reflects the value that unpaid carers do, but also how vulnerable we are to those unpaid care arrangements breaking down, and how much pressure there are on the unpaid carers and the people they care for. I'm sorry, I keep seeing the messages crop up actually. So that's dreadful. It's not dreadful the cleaners man did, but actually it does illustrate, I think, my point really well. You might say, well, what's the government done in response to this? And the spending review last year, it was the most generous for local government for some years. It gave us broadly about £3 billion for authorities that are responsible for social care. The pressures earlier on probably would take up more than half of that, just more than half of that. So you might say, well, that's quite good because you've got more money left then. But the difficulty is that we face pressures elsewhere beyond adult social care, children's social care in particular, but a range of other services. Homelessness is a good example of an issue which many local authorities are struggling with. And it's also worth making the point, and I know local authority leaders would want me to make this point, is that those extra resources is very much dependent on increasing taxes on local taxpayers, either through the general council tax or through the adult social care precept. So overall, I think our view is, for most authorities, yes, there is enough money to deal with demography and inflation next year, so that it doesn't get immediately worse because of those pressures, but there's not enough to address other issues, such as stabilising the market or addressing the workforce. What's even more worrying, that spending review was for 1 year only. So at this point in time, we have no promise of extra resources for the financial year that will begin a year tomorrow or the year after that. Other than there's talk about, well, you can have a counter tax increase and you can have a 1% increase in the adult social care precept. We know inflation and demography of at least £1 billion, probably closer to 1.5 billion actually, in 23-24. What it will be in 24-25, I think it's a bit difficult to project at this point in time, but the council tax increases won't give enough money for the adult social care pressures, never mind the other pressures there will be on local authorities. And all of that assumes that all aspects of adult social care reform are funded adequately, and I'm afraid there's no sign at this point in time that they are going to be. If we move on to the next slide, please. So I want to say a little bit about COVID. I'm not going to go into loads of detail about COVID, and that's partly because there's a lot of obvious issues, but actually, if we can move on to the next slide, a lot of obvious issues, but they're not necessarily easy to quantify. But let me just mention some of that. We've had a lot of people, generally overall, particularly at the beginning, but to some extent even now, we're seeing more people discharged into care homes from hospital rather than ultimately getting home, and at more expensive rates. So that's been an issue. Particularly during the first year of the pandemic, with a lot of lockdowns, there were services that people relied on, particularly unpaid carers, such as day services, just disappeared. They had to be closed down for safety reasons. And that has increased the pressures on unpaid carers. And the real problem is, if they ultimately are worn out by those pressures, then there is no option other than formal care, and often things, expensive formal care, such as supporting people in care homes. There will be, local authorities have been trying to manage these pressures by looking to think about who might need care and thinking about ways in which you could support them in a different way through using resources in the community, or the assets available to the individual themselves. Those sorts of initiatives have been much more difficult over the last 2 years because of the lack of availability of services, and because the inevitable focus has been on managing the pandemic and the consequences, the acute consequences for the NHS and parts of adult social care. So there's been a real issue about how do you deliver some of the savings programs that people had, and then we need, people generally will say, yes, give care workers a lot more money, but that's not happening really. 6.6% is an important increase, but actually it's not huge, especially if people are losing out with what's happened on benefits and so forth. So there's some real issues around that, but we've also got the issues which are mirrored in the NHS: burnout, low morale, and the specific issue for adult social care, the compulsory requirement for vaccination, which of course has now been withdrawn, but did undoubtedly impact on who was prepared to work in adult social care. I think the one positive thing I'd want to say is, I think that this is an opportunity for us to see this as a reset, not restart. And for example, I think the pandemic has raised some big questions about whether care homes are always the best place to support people with complex needs, and there is scope to offer them something better. I'm confident about that. If we move on then, please, the next two slides are data that ADAS has been collecting over the last 9 months. And what they do is, and the latest survey is due to come out next week. And what they did was they looked at the numbers of people waiting assessments, the numbers of waiting more than 6 months for an assessment, the numbers waiting for care and support following an assessment, and the number of reviews overdue. Normally you'd review somebody every year, and apart from the last one about reviews, there has been the position has got worse, and in some cases very, very much worse. So if we look at the numbers of people waiting assessments between July, the first survey, and the survey they carried out in November, the numbers of people waiting for assessments quadrupled. So it went from 50,000 people to over 200,000. The numbers waiting more than 6 months increased nearly 6 times, from 7,000 people to waiting to over 41,000. And the numbers, the numbers waiting for care and support following assessment also increased, although not as significantly, which is positive, because obviously once you know somebody needs a care need, that must be met as soon as possible. Reviews actually has only increased marginally, so it's possibly a bit more of a success story. But overall, that's a very, very bleak position, and I know ADAS is extremely concerned about that, and will be wanting to say more about that, I suspect, next week when they launch their latest survey. Move on to the next slide. One of the issues that NHS colleagues might be saying, well, what have you been doing in response? You know, you've talked about all these problems. Does that mean that the amount of care that's available has fallen? And the fact is, actually, the amount of home care, which is, I think we would say, is for most people almost certainly the preferred way of supporting them. The amount of home care hours delivered went from 34 million in the period February to 80 to over 41 million in the period October. So that's an increase of 15% over that period, which I think is very positive. The worry is the numbers of home care hours that could not be delivered went from under 300,000 to over 1.5 million, which is an increase of 160%. So that's really, really worrying. Okay, I'm going to move on because I'm conscious I'm just about out of time. Just want to say about adult social care reform. It's probably worth saying we're quite early days on adult social care reform. The government's just put out some draft guidance about charging reform, and they've also just issued some guidance on what's called fair cost of care. I think the key point I want to make, there's a hugely complex policy agenda here, which builds on top of the underlying pressures and the impact from COVID. So just to go through the policy agenda for adult social care, we've got adult social care reform white paper, good paper, not much money in it. We've got health and social care integration. We've got the fair cost of care. We've got charging reform. We've got new developments in terms of the assurance of social care that Care Quality Commission is developing at the moment. And we've got the potential implication from the Messenger Review of Health and Social Care Leadership. And then to move to my final slide, financial implications of that are unclear at this point in time, but depressing, I think, will be my description. The white paper comes with some resources, which is welcome, but much, much more is required if we're going to deliver our collective ambitions and the underlying pressures. One example would be there is some money available to invest in housing options to help with care, but actually the quantum is almost certainly going to be massively greater than the amount the government's identified. Integration, I think, if it works well, can help us, and by us I mean health and social care, to use resources better, but only if the relationships are right. Charging reform combined with fair costs for care is probably the biggest new financial risk, particularly for some local authorities who have a lot of self-funders. A recent report from the County Council Network, which did cover all local authorities in England, suggests that the costs are under-resourced by a minimum of £850 million a year. And the difficulty is none of those reforms tackle the underlying pressures. That's a problem. They don't do anything about the workforce, which actually I think if significant increase in pay for the workforce will be billions of pounds really to do that, and they don't address the COVID backlogs in adult social care, which appear to be getting worse.
Thank you, John. You promised bleak, you didn't disappoint. It's so many sobering points there. I think a lot of delegates were struck, particularly I think by your points on workforce. The vulnerability, the vulnerability both to our paid and our unpaid workforce, and the lack of strategic policy thinking on that vulnerability. Jane Burns asked a question about assurance requirements. Jane, I don't know if you want to just pop yourself on, mute yourself and ask the question.
Thank you, Richard. Yeah, just interesting to hear what John's thoughts are on how those assurance requirements will develop, please?
I think it'd be fair to say, Jane, that it's relatively early days. So there is work going on. Care Quality Commission is leading on it, obviously working with DHSE, and there is local government discussions with them. But there hasn't been much that's come out that's public at this point in time from that. I think the driver for this was a ministerial view, which is that we really want to understand how well adult social care is doing, which I think is a completely legitimate question for them to ask. And the question then is, how do you assess that on the basis of what's available at the moment? Linked to that, I think there's a general disquiet across the whole of the sector about the quality of the outcomes framework that we've been using for adult social care, and about how many of those particular indicators are useful. So all of that's being reviewed. Quite what will come out at this point in time is a bit difficult to predict. The challenge is going to be that CQC is keen to have something that operates from the 1st of April 2023. So I think that will be an issue. There's the other question about how does that link with their assessments of how well integrated arrangements are going to work, where they've just advertised for a director's post on that. So I think this should be an interest to everybody attending, really, because I think inevitably this is going to be a question for the health service as well as for adult social care.
Thank you.
Yeah. Thanks, John, and thanks, Jane. I was going to ask you actually, John, just on the integration agenda. I mean, this is the challenge, isn't it? And to what extent has the introduction of ICSs or ICBs moved us towards or away from integration? I think I sit on a number of ICB boards. It depends on which board you're sitting on as to whether you think there's a partnership or an invite, a grudging invite to the table. I mean, how do we properly go forward towards an integration agenda?
Well, I did say in my presentation, for me, in working with health is very much a matter of relationships. When it became the DAS in Oxfordshire, I was blessed with a long history of really good, positive working relationships across health and social care, across all areas. It wasn't so much actually with the acute hospital at the time, although those relationships developed. But actually, there was a history of really good working on mental health and learning disabilities. But there was generally good working relationships, and over time we built that up. So we had very big pool budgets, for example, which covered significant amounts of health spending as well as adult social care spending. But that was entirely down to relationships. You know, if the NHS is grudging about asking local government to come to the table, then I can't admire those people. It doesn't seem to me they're acting in the interests of people who need health in the best way, because adult social care is really critical. It's critical to things like the back end of the hospital, but it's also critical if it works really well with stopping people needing to go to hospital. And as you said, Richard, the social determinants of health, you know, the leader on that is local government. They've got a specific role. They're responsible for a very wide range of services. And the other thing it's worth saying is the leaders locally, politically, are local politicians, and they can be very, very influential in terms of the role that's done. And of course, you've got within the Northwest, you've got two, you know, very outspoken. That's not meant to be a criticism as well, by the way, but two very outspoken mayors, which is, I think, broadly the role. It's the same issue in the Northeast with the mayor for Tees Valley, who's a different political election. But I think all three of them have been speaking out in their areas, and that's a really important role. And I think health can use that very well locally, but it is dependent on people taking the right attitude. Simply not wanting people at the table seems to me a recipe for a disaster, if you don't mind me saying, Richard.
No, I completely agree, John. I think it's relation. I mean, I talked like my presentation about place-based leadership, and I think that for me is the key, relationships at place level.
Yeah, I mean, I should make the comment. The reservation I think local government has had with the development of the integrated care partnerships is the geography in some cases, which I know is an issue in parts of the Northwest. There's a practical problem, which is about what is the best way to organise a health system and how is local government organised. and they don't always match. But what I did like what was in the NHS long-term plan about the distinction between work at an ICP level and a work at a more local level. I mean, ultimately, you need to go down to the primary care network level. I think that's really, really important for both adult social care and for adult social care. But I think people need to recognise what can be done within a local authority area or within a local authority sub-region. I mean, that's the other issue for you in the Northwest, because you've got strong sub-regions in for both Liverpool and Greater Manchester.
And a quick final question from me, John, before we move on to Chris. I'm going to obviously come on to workforce. What, if anything, is the solution to how we make careers in the care sector more attractive and at the same time help to support our unpaid carers as well, as you mentioned? Is it simply money, or is there something else we could or should be doing?
I think a lot of it is money. I mean, you know, I know ADAS has been making a public point about the sort of salaries that people like Amazon are offering for working in a warehouse, of something like £13, £14 an hour. Somebody in the chat mentioned £15 an hour for cleaners. I don't think you can get away from the fact we've got a really low paid workforce here, and nearly everybody's paid at the legal minimum. And question whether everybody is properly paid, because there is some question about whether all practice is reasonable. But I think it is also about thinking about the terms and conditions of employment, about how you can move towards, say, a salaried workforce, thinking about how you use it better and so forth. But it's not an easy solution. And there is the challenge, the fact that, of course, we've got 10,000 different employers working in the area, because there's a lot of very small organisations as well as big organisations providing care.
Yeah. John, thank you very much. I'm going to move us straight on to Chris's presentation. So many of you will know Chris from his work as Chief Executive of NHS Providers, and he's spoken at this event for the past 6 years. We're delighted he's back again. Chris joined NHS Providers as a Chief Exec following a career spanning the public, private and voluntary sectors, and he's going to be sharing his analysis on system pressures over the past 12 months and what Chris believes the future will hold for both recovery and transformation for services and, of course, the workforce. And as always, there's time for questions for Chris after the session, so please do pop any questions you've got for Chris in the chat box, and we'll come to you after he's finished his presentation. Chris, lovely to see you.
Thank you very much indeed, Richard. Delighted to be with you. One of the features of my calendar is this event, so delighted to be back again. Just in case you're a bit confused about the background, I'm actually not at home. I'm in the office of the Chief Executive of the Royal College of Physicians, because I'm dash off at the end to do a turn at their conference today. So just in case you were wondering, where's the mantelpiece and the vases, that's basically why you can't see them. So look, what I thought I'd do is just give you a kind of sense of, which is what I usually do when I do this event, is just give a sense of how it looks at a very top level from our perspective. Just to remind you who we are NHS Providers. We are the membership organisation for the 211 acute community mental health and ambulance trusts. So we're very clearly a kind of NHS secondary care perspective. I think it's really difficult to start an overview of where we're up to without reference back to the last couple of years. I mean, it has been an extraordinary 2 years, and just think about some of those fantastic achievements: 34,000 beds created at the start of the pandemic, you know, the way that we expanded critical care in January 2021, preparing and dealing with the Omicron surge, December, January. You can argue it's still going on in terms of hospitalizations going back up again. The vaccination campaign, which was extraordinary, but also things like the recovery trial and the way that we as an NHS have developed COVID therapeutics. It's obviously had a huge impact as well, not just in terms of the loss of life, but also in terms of potentially long COVID, and also I think long-term ill health. I mean, I still don't think we know quite what the impact is going to be. And I think something that particularly concerns me and us is the fact that that impact has been unequally distributed across our society. And again, I know, Richard, that's something that's very much top of your agenda. Clearly, we have a set of care backlogs that have now resulted. We are still struggling significantly with lost capacity due to infection control. One of the very big kind of unknowns at the moment is the speed with which we can pull down those infection control measures, and therefore how much capacity we can regain how quickly. I personally think it's important to kind of recognize in terms of the fact that this has had a disruption on the rhythm and focus that we had prior to going into COVID on things like, plan change programs, but also on efficiency savings and tackling underlying financial deficits, and clearly a very, very significant impact on much of our workforce. I'm going to try and be match, and this is in a sense one of the themes of my presentation, is the challenges are enormous, but I think it's very important we don't talk ourselves into an embattled and beleaguered state, and I think it's important that we retain our resilience and optimism and positivity. So I think also as part of the last 2 years we've got some clear signposts of future opportunities in terms of, I just think the size and the speed of the transformational change that we made just give you a sense of how quickly and rapidly the NHS can change things when it needs to. I think definitely a sense of new ways of working and workforce flexibility, the speed with which we adopted digital technology. And again, I'm very, very struck by when I asked them also, what's the single thing you pulled out of the last couple of years, that real sense of collaborative working, both at a vertical place level in terms of, primary care, social care, local authorities, the NHS working together, secondary care providers, but also that horizontal collaboration in terms of, for example, acute trusts in a broader system working together effectively. So next slide, please. I did want to start, though, in a sense, the next bit of the story for me is we just need to remember that before we went into COVID-19, we were struggling. And I think we do need to remember that we had these 4 fault lines that had basically been building over a decade. We'd had the longest and deepest financial squeeze in NHS history, and that basically meant that we had not been able to grow our capacity to match the growing demand. We were struggling with a series of workforce shortages. And again, I think as we've just heard very articulately from John, we'd had real growing pressure in social care. So if you go on to the next slide, what that basically meant was, if you look at the 3 red lines on each of these 3 charts, so from the left, it's A&E attendances, it's patients treated, cancer patients treated within the 62-day waiting time target. And then on the right-hand side, the number of people treating elective surgery 18-week target. On each of those 3 red lines, from a period between 2010-11 and 2019-20, performance in all of those 3 areas was very significantly under pressure. And to be frank, we tend in the NHS, or we have in the past, focused on those acute hospital metrics. But if we were able to draw similar metrics for virtually in my view, every other area of activity of the NHS, we would see a similar picture. So as a result of those fault lines, NHS performance was under huge pressure before we hit COVID-19. And although we were doing a lot more, the reality was we were still, although we were running fast, we couldn't run fast enough to keep up with the extra demand. So we had got that decade of declining performance despite the frontline effort. So next slide, please. So where does that leave us at the moment? I think there clearly are some very big challenges. I mean, I could have done 2 or 3 slides on all of them, but effectively, here's my sort of take on what are sort of 10 of the biggest challenges. We've clearly got a very unstable at the moment urgent and emergency care pathway. We have got significant care backlogs. As I've said, we've got workforce shortages, which are now becoming more acute. We do have, I think, a recent major deepening of the problems in social care, as John's outlined, and clearly, and it's not the only factor, and let's be very, very clear that discharges are also a function of how well the NHS is performing, but we've clearly got a very significant issue around prompt discharge at the moment. We're also at the same time trying to go back to tight financial discipline, and their 22-23 task, I think, is going to be rather harder than some people seem to be thinking. And we've clearly also got to deal with this kind of COVID-19 impact ongoing. As Chris Whitty was saying a couple of weeks ago, yes, we are headed towards more of an endemic state, but this is going to be seasonalized, it's going to be bumpy, and we are still going to need to ensure that we protect vulnerable people who use healthcare settings. So there will be some capacity impact on infection control. At the same time, if we're going to really, really make systems work, we've got to move as fast as we can to effective collaborative system working across ICSs, places and provider collaboratives. We've also got, in my view, some overinflated expectations of what the NHS can deliver for the extra funding, which is already being eroded significantly by the impact of inflation. And I think then, and this was absolutely, you know, the day after, you know, that King's Fund Nuffield Trust release of the latest British Social Attitudes survey yesterday, showing there has been a very significant drop in terms of public confidence in the service. So if you add all of that together, I mean, I've gone through my last 9.5 years doing this job of thinking, blimey, this is the most challenging bit yet. My kind of sense is, yet again, it feels to me like the level of challenge feels like it's kind of gone up again in terms of where we kind of now are. And not to make the comparisons to the last couple of years, but I think that there is a real sense of, in the last couple of years, we've had to really focus very, very hard on a sort of single issue, like those 34,000 beds, or actually we've got a real problem in terms of the second wave last January. I think what characterizes the next phase for me is we've clearly got a period of extended pressure across a number of different fronts that are going to really, really challenge us. But as I said, there are also some significant change opportunities here. And for me, 21st century personalized genomics-based medicine, I think, offers some fantastic opportunities. That idea that you can do a prick on your finger and get a small drop of blood and identify your propensity to 60 cancers just on the basis of a single finger prick. That's revolutionary, it feels to me. There is a real chance, as we've said, to integrate GP social care, primary care, social care, community mental health, community services, and basic diagnostics focused on place. I do think there's some very exciting things kind of going on. If you look about, for example, what's being achieved in Manchester, for example, by creating the Greater Manchester collaboration of trusts, that seems to me to be a good example of where provider collaboration can really start to drive some pretty rapid change. I do think there is an opportunity to use ICSs to reorient from illness treatment to health and wellbeing promotion. This idea of really focusing, that Wanless was talking about 20 years ago, about focusing on prevention and whole population health management, including tackling those health inequalities starkly revealed by COVID-19. All, I think, underpinned by more effective use of digital technology, both from an NHS organisational and an individual patient perspective. So I am quite optimistic. I think somebody described it to me as, we have got a set of short-term challenges, but we absolutely have every right to be optimistic about the mid and longer term. But for me, we've got to address four underlying issues, the issues I was really talking about earlier. So next slide, please. The first is capacity. I do think that the last decade's financial squeeze, as I've already said, has meant that the NHS has been unable to grow capacity to match growing demand. And I do think that today's problems are significantly driven by a capacity demand mismatch. I think the reality is, if you just look at it, just the pure demographics, but rising expectations, new treatments, continuing growth in the need for acute care, it feels to me pretty obvious that demand for care is going to continue to rise. So, and that's not new, and that's not just us, it's every single advanced Western nation is experiencing this increase in demand. So I feel quite strongly, and it's one of the things that, if I'm honest, slightly surprised me about when I arrived in the NHS, is the fact that given this kind of demand capacity match is a pretty fundamental part of the NHS, I do think that that sense of proper, robust, honest capacity planning for the short, medium and long term needs to sit at the heart of the NHS. And it's easy to think that means more hospital beds, and that's absolutely not necessarily what I'm talking about. Actually, we do need to be clear about what a 21st century model of care looks like. It's pretty clear that that will involve more care closer to home. I think we can all agree, can't we, I suspect, that actually we should be reserving acute hospital care for those who absolutely need it. And as we've said before, a real issue around the number of people who are currently unable to leave hospital, even though they no longer medically need to be there. So actually, it may well be that in lots and lots of places, the extra capacity doesn't need to be provided in terms of acute hospital capacity. It's actually more about innovative ways of treating people closer to home. But that fundamental issue of capacity and demand match feels pretty central to me. The second issue, next slide, is workforce. And I've made a pretty bold, clear statement here, but it feels to me to not be particularly controversial, which is that our current workforce model is broken. What we're trying to do is cover that capacity demand mismatch by asking our staff to work harder and harder. We have got persistent workforce shortages. We're now back up to over 100,000, 110,000 vacancies, the last set of figures shown, and we're currently covering that by £6 billion of temporary staff spend, which again doesn't seem to me to be a particularly kind of logical kind of approach, in terms of ideally you'd want your staff spend, wouldn't you, to be spent as much as possible on kind of permanent, really good quality jobs. And I do think, and I think this is the bit where for me the people plan hit the nail on the head in a really helpful way. And I still feel that we haven't quite absorbed the lessons of the people plan, which actually felt to me to be an important contribution to the debate, which is we still are effectively a 20th century employer, in terms of sort of thinking that we're going to have people who are with us for life and who are happy to do whatever it is, 35, 38 hours a week. And actually the reality is that the 21st century workforce requires a rather different set of relationships, for example, a much more employee-focused approach to flexible working. So we need proper, robust, long-term workforce planning. I know that Anita, who's about to come up next, will endorse that, because she and I and a bunch of others have been talking to Jeremy Hunt and a bunch of other people over an extended period about how we might get that need for robust long-term workforce planning into the current health and care bill. But I think for me, as with physical capacity, honesty around the shape and the size of workforce needed to meet growing demand. And Anita will concede that I've shamelessly stolen on the right-hand side of the slide some stuff from some work she did last October. But I was just incredibly struck by, and it was a really, really great, simple point that she made, which is by 2030 to 31, we will need 1 million more health and care staff if you extrapolate where we are, where we are likely to be in terms of demand profile compared to where we are. And bottom half of the box, in the next decade, the NHS workforce would need to grow twice as fast, and the social work care workforce 4 times as fast as it did in the previous decade to meet demand. And if we all looked at ourselves and said, are we shaping up to get anywhere near that? Are we doing things now that would enable us to have confidence that we could get somewhere near those figures? My view would be absolutely not. So we also need, in terms of, there's a lot of phraseology at the moment that we've got the workforce that we've got for at least the next 2 to 3 years. So how do we deal with the fact that that is going to be a very significant constraint on what we can kind of do going forward? So that in terms of the, so I just flip back to the previous slide, sorry. And also just the final point would be that we also do need to think more flexibly. If we're to make maximum use of the workforce, we really do need to think about exactly how we might ensure that we get more flexible roles and more flexible entry points in terms of people coming into the workforce. At the moment, we've got a workforce that's very much based around people coming in at the age of 18, 19 when they leave school and you leave university. Or go to university. But actually, if you look at places like Singapore, they place significantly more emphasis on the way that people can actually join mid-career. So third area we really need to sort ourselves out on is funding. We clearly need to repair the impact of the financial squeeze that we've had over the last decade, and the very obvious place to point to is the massive capital backlog that we've got. We do need to recognise there will be a cost of that COVID-19 impact. So, for example, on backlog recovery. We do also need to, if we genuinely, if you agree with my contention that we are going to need to properly plan how we grow capacity and workforce to meet the growing demand, we are also going to have to fund the required expansion that's needed. Obviously, it's a difficult. I mean, we in the way that we make our contribution to the national debate, we obviously need to be careful about when we talk about funding. And clearly, funding at the moment is not something, given the combination of the spending review and the fact that we've also just having to increase the health and social care levy to pay for the extra funding. Now is not a time that it feels like it's necessarily a good time to be banging the drum publicly. But we just need to be realistic about what that extra funding has done. It only takes the NHS back to the long-term average annual increases of 3.8%. And actually, if you look at it, that is now being eroded, as I said, by inflation. It's also being eroded by probably we will need to increase pay. We're also now, we've clearly got a Ukraine impact, for example, on energy bills. And we also are now having to find an extra £500 million this year because the government has decided, or the Treasury has decided, it won't fund the ongoing costs of COVID-19 infrastructure and testing. We need to make the point that, and this is one way of talking about it, if you look at what we achieved in the early 2000s, which was, the last time, you might argue, when the NHS was this stretched, and where we actually did some fantastic work in the early 2000s to cut waiting lists, don't forget that that was basically as a result of 3 or 4 continuous years of 6% per year financial increases. And I think there is a very interesting, and the bit that I thought was interesting about the Secretary of State's recent reform speech was the way in which he was very, very clearly positioning, as far as he was concerned, the fact that the NHS simply can't carry on receiving the kind of increases that it has received. So I think, there is an argument that the health and social care levy may well have changed the terms of the funding debate. I still believe that we do need that proper, honest national debate about what is the long-term health and care funding that is needed to meet growing demand. And we just need to size our expectations on what the NHS can deliver for the funding that is available. We're forever trying to pretend that actually, if only, leaders were a bit more efficient, if only we could squeeze out a bit more, efficiency, if only we could increase productivity a bit, if only we could, cut out all of this waste and needless bureaucracy, everything would be fine. And it's just not a sensible debate in terms of framed in a way where actually, yes, of course, all of those things we could do better, but they're not going to be transformational in a way that kind of covers the funding gap that is likely to exist if we do want to grow capacity, both physical and workforce capacity, to meet the demand we've got coming down the track. Fourth area, next slide, please. I suppose for me, it's really this. It's a bit more sort of esoteric, but as I was implying earlier, I think the NHS is at its best when it combines excellent day-to-day care delivery with ambitious transformational change. But it seems to me it's very difficult to strike the right balance. And I think some of you will know, I've worked for a FTSE 100 PLC, I've worked for one of the largest government departments, I've worked inside being a political advisor. So I've been in a number of different systems. And the observation I would make about the NHS is the sheer day-to-day pressure that the service is under seems to me to squeeze out its ability and capacity to deliver the transformational change that's needed. And we know there is that huge pressure on operations. There's no doubt that it's where the political leadership kind of focuses. So if you ask people, well, how's the NHS's success going to be judged over the next 2 or 3 years? It's really, it seems to me, if you ask the political leaders, it's primarily around our ability to get through those elective care backlogs. There's no doubt that the NHS culturally is also kind of configured to focus on to day-to-day operational issues. It's where all of the reporting sits. It's where all of the assurance and regulation and oversight sits. And there is this kind of sense of the fact that we are so under operational pressure and there are so many operational challenges that they just tend to consume and dominate bandwidth. At the same time as we've got these funding pressures, which means it's very difficult for us to do what most people do, which is double run in terms of create a new transformationally changed system whilst you're transferring across from the existing way of doing things. And we just don't have the bandwidth to kind of, or the financial bandwidth to do that. And it's very clear there are some pretty big structural barriers in terms of, driving change. We know that, for example, organizational silos have prevented us from, for example, driving the integration that's needed. So I suppose what I'm trying to argue is that there are a whole bunch of factors which are, in a sense, locking us into this very, very, very strong operational focus. And that's, for me, at the expense of the ambitious longer-term transformational change. So carry on to the next slide, please. So I do think there's a question we need to ask ourselves, which is, have we now reached an inflection point? Will more beds, more clinicians, more funding, more efficiency and more productivity be enough? And that, if you look at the scale of the challenge and you look at the workforce constraints and the funding constraints that we are likely to face, and if you look at the public-driven demand for 21st century medicine and digital, and if you, which we're beginning to kind of see now in terms of people saying, well, hold on a second, if other countries can make this transformational change, why can't you? If we are now getting our driving licenses online, doing our tax returns online, why can't we book hospital appointments or community service appointments online? So I do think there's quite an important question we need to ask ourselves is, what's our appetite for, and what scale of change do we think we need? And we can carry on, in a sense, trying to run faster and faster on the existing hamster wheel, or we could ask ourselves the question of, actually, do we need to be much bolder, much more effective and much more rapid about the way we do our transformational change, recognizing that brings risks, recognizing that there are a whole bunch of areas where we could undertake transformational change, but what are the priorities? But also asking ourselves, what's the change model? Is the model that actually we are looking for our political and national leaders to set down a blueprint? Or are we actually saying that we want ICSs to be the place that actually decides what's the best transformational change to drive? The point I suppose I'm really trying to make is, given the scale of the operational challenge we've got, it would be really easy for us to just focus on meeting those day-to-day operational challenges and just say, oh, look, the longer-term transformational change is too difficult. I think my worry about that is that we end up being the boiled frog, where we effectively haven't done the things that we needed to do, and find ourselves in 5-10 years' time where actually we simply the model has clearly become unsustainable, and actually public confidence has dropped so much that actually there is a real issue about the long-term future of the service. So I suppose I don't want to make it over dramatic, but I find it interesting that we don't seem to be having that kind of debate in the way that I think, if you looked at any other organization in our strategic position, I would expect that organization to be having this kind of debate in a way that perhaps we're not, being slightly provocative. Next slide, please. I therefore do think we need a new NHS strategic framework that brings together and prioritizes what we will deliver when from the NHS long-term plan, that basically does recognize we are in a new situation that's very different from the one envisaged in the long-term plan. So what does COVID-19 recovery, particularly care backlogs, look like? What's needed to deal with COVID-19 longer term? What is the kind of transformational change program that we need to do with an appropriate scope, focus and change model? How does that match to the available funding envelope? And how do we get the clarity and honesty that we need to how we do grow the capacity in our workforce to get to a sustainable long-term position, all in that new emerging context of system working? Next slide. So for me, as I've said, it's optimism, resilience and realism. We do, as I said, need to be optimistic about the fact that whilst we've got lots of very difficult challenges, and it would be easy to become embattled and beleaguered, we actually need to maintain, particularly for our frontline staff, we need to maintain that sense of, we will get through this period. There are some fantastic change opportunities we need to take advantage of, but we do need to be realistic about how long it is going to take to recover from that decade of growing fault lines. We need to be realistic how far the extra funding will actually go. We need to be realistic about how long and extensively those workforce shortages will act as a rate limiting factor. I do think we need, as I've said, a clear view on the scale, place and scope of change. And I suppose I wanted to sort of finish by saying, kind of in an environment where the NHS is under significant challenge, you can see that a narrative will develop. And, you can see it in some of the comment pieces, particularly in the Daily Mail and the Daily Telegraph over the last 48 hours, that somehow the NHS is inefficient, the NHS is poorly led and managed, et cetera, et cetera. And I do think we need to be robust in basically saying that you just need to be realistic about, you simply can't deliver top levels of internationally comparative care with below average levels of funding. And I think we need to stop pretending that somehow that, this kind of rather silly argument, in my view, that somehow the NHS is a bottomless money pit, when the reality is that all advanced nations are having to meet growing care need and increase their funding for health and care. And the reality is that our system, and I don't see appetite to basically challenge this core principle, is that our NHS is funded through taxation, and if you want to grow funding for, particularly on the health side of things, you can only grow that through increasing taxation. So if I was to sum it all up, I think we have got a difficult period ahead. There are some difficult challenges to surmount. I think we will, as ever, be incredibly reliant on our front line to step up to that challenge. But I think as leaders, our challenge, or one of our biggest challenges, is to retain that sense of optimism and resilience and avoid becoming, as I said, embattled and beleaguered, and to just help people see there are ways in which we can transform the service at pace, as we did over the last couple of years. That means that actually we can stabilise the service, and there is a sustainable long-term vision for how this wonderful model, to which we're all very, very committed, can sustain going forward. Final slide, I think. There we go, questions and answers. Richard, I hope that's helpful.
It's brilliant, Chris, absolutely brilliant. I've been scribbling away, and we've got some questions in the chat as well. I think your 4 areas of focus, I think, is probably where we'll start with the questions. And just so everyone knows, we only have Chris for this next 10 minutes, then he has to dash, as he said. He's got other presentations to give. So if you have a question for Chris, now is your chance. Chris, I was going to start where we left off with John, which was about workforce.
Yeah. And
your point about the £6 billion worth of temporary staff funding that we're currently spending. I mean, that's, to me, sounds like a massive red flag to the system, that we haven't got our workforce offer right, and that people are choosing other ways of being engaged by the NHS rather than being part of our kind of more long-term permanent staffing offer. And I just started to make a list to myself, pension tax, the lack of ability to work virtually, part-time working being a problem, the benefits that we don't offer compared to maybe comparable jobs in the private sector, pay in and of itself. I could have probably gone on for longer. How do we increase the attractiveness of permanent NHS careers? And also, I suppose, how do we do that without maybe potentially decimating social care workforces further, as we heard from John?
Well, I think that they're all really good points, Richard, in the question. So let's go for the last one first, which is we've got a real challenge, haven't we, to do proper integrated workforce planning. And I hear so many people who talk about the real dangers of, particularly at the moment, in terms of denuding social care. So I think it's incumbent on all of us in the way that we do our work to ensure that we take an integrated view. I will go back to the people plan on the rest, if I may, Richard, which is, I thought what the people plan said to us is that in the past, we've basically tended to treat NHS workforce planning as a pure numbers game. How many of this, how many of that, when, where? And actually what the people plan said is, if you want to be an effective, sustainable 21st century employer, you've got to become much, much more focused on how do we create a fantastic, make the NHS a great place to work, and how do you, because you are the people that actually run, local trusts, etc., how do you create a really exciting and fulfilling place to work? And some of it is hygiene factors that we know about. So if you talk about the junior doctor workforce, we know there is some really basic stuff where we are not meeting their requirements, meals at night, that kind of stuff. But some of it is also about, as I said, getting in the 21st century, which is one of the reasons. One of the reasons we don't say that the whole 6 billion is invalid is because we know there will be some people who want to work flexibly and will only be prepared to work flexibly. And at the moment, the only way they can do it is by being locums and being temporary staff. But what we need to do is get to a place where actually we've got employment patterns inside trusts where if you want to be a flexible worker, you can be a flexible worker, and you can feel a very strong sense of your commitment to your single trust where you work, and you don't feel that you actually have to kind of go on the, on locum or agency. But that requires a slightly more greater investment in terms of thinking through how do you create those shift patterns, how do you work them into your workforce planning. So this is one where I think we've all got an individual responsibility to make it work as best as we can in our own individual organisations.
Yeah, I think you're absolutely right. And I think culture is key there. I think your point about it being a numbers game traditionally and recognising that we're now in a competitive workforce environment is absolutely spot on. Just a point on the agency piece. We've already got innovation in the system, which is demonstrating how the NHS can be more flexible in-house. So there's a brilliant GP in Bradford called Taz, who's got an innovation called Docabode, which allows staff to switch on or off discretionary capacity as it suits their weekly lifestyle. There are things that we already know. It's the spread piece that we're just not getting these things adopted at scale. But we have solutions, I think, which are well worth a look. I'm going to go to Andrew. Andrew wants to pick up on the operational pressures piece that you mentioned. Talk about that being a barrier to collaboration. Andrew, do you want to just phrase your question for us? Put on your camera as well, if you like.
Hi, thanks, Richard, and thanks, Chris. Just a quick one, Chris, that obviously with the operational pressures at the moment, I could see trust leaders being very focused on delivering what they have to deliver and then seeing collaboration as a secondary priority. How can we incent trust leadership to collaborate by default rather than perhaps instinctively reacting to look after their own performance?
Well, I think the key is to link the two together and actually work out, which is often the case, that actually if you look at the operational pressures, how are they best delivered? And the elective recovery is a very good example for me. Manchester is a great example, is effectively the way that they got to, I think it was, Amanda was saying to me, something like 110%, I think, of pre-COVID levels of activity, was because they took a cross-Manchester plan to work out how did they all work together to create particular hubs and particular areas of expertise. So I think the key, in a sense, is to solve today's problems or to work out how you can solve today's problems in a collaborative way. And I think the reality is, and we sort of tend to talk collaboration sort of rather abstract and well, let's go and do some brand new stuff over here. But if you've got a collaborative mindset and you apply it to the problems you have in front of you, you can often kind of actually get better solutions. And it's very clear to me, as I said, over the last couple of years, if you look at some of the stuff like, for example, the way that PPE was shared, if you look at the way that actually people did carry on elective activity, if you looked at the way that, for example, people were working incredibly tightly between mental health and physical health to ensure we had appropriate emergency services, emergency crisis services available, that actually people suddenly realize, well, not suddenly realize, people realize that actually how much collaboration potentially can bring to make more effective delivery. So I do think there are, the key is to, combine the two, if you get my drift.
Yeah, thanks, Chris. Ruth, importantly, you're going to bring the patient voice into this. Do you want to just ask your question, please, Ruth?
Hi, I just put my video on. The question I was asking was really around patient voice and also about co-production. You talked about a change model and having a kind of realistic change model. I just wondered what part you saw that type of work playing? You previously spoke in your answer around collaboration and the importance of that. National Voices have recently produced a new toolkit that really looks at how mentoring can be set up with people who use services to really support that change that is needed. And I think it begins to address some of the issues around demand. So I'd be interested in hearing how you see that playing into the work you've described.
Yeah, and I think Ruth, it's absolutely the question is spot on, which is I'll link it to this basic point that Wanless was making, which is if we carry on being a national sickness treatment service or an illness treatment service, and we don't turn ourselves into a national health and well-being promotion service with a lot of the, with our the people who we serve, then the model becomes unsustainable. And if you sort of take a 10, 15, 20 year view, where I think we would like to be would be, have we got a bunch of technology and healthcare professionals who can really help our citizens stay much better and more healthy and look after their own well-being much more effectively? And sitting at the heart of that has to be a fundamental rethinking of the relationship between the health service and those individuals, where at the moment the model I think is quite a paternalistic, we're all the experts, when you get ill come to see us and be grateful recipients of our very, very deep medical knowledge of how we're going to kind of ensure that you're not we treat your illness and sickness, into how can we be co-creators with you to help you and support you stay as healthy and promote your well-being and and health as long as possible. And yes, of course, when you do get ill, we will be here. But actually, if we can't make that shift, which I think fundamentally challenges this paternalistic expert delivery of expert knowledge and expert treatment into much more of a collaborative model, I think we're in real trouble in terms of the sustainability of the system. I do also, and you absolutely have to say this the day after Ockenden, is there is also no doubt that listening to patients more carefully in secondary care and sickness and illness treatment is also really, really important. And I think one of the shocking bits, I think, for anybody who's read the Ockenden report is the degree to which, the medical, healthcare professionals seemed to be unable to listen carefully and clearly to what patients were saying, and that as a result, some very, very difficult things kind of happen. So I suppose that kind of, and I recognize all of the complexities around, for example, the level of risk that sits in maternity services, but I think it's a pretty clear pointer to the fact that the way that we do our job most effectively absolutely has to be patient focused, and it absolutely has to be listening carefully to patients, and it absolutely has to be improving on the basis of that listening. But it's also fundamentally, if we're going to make that shift to promotion, it's about a very different relationship. Does that make sense, Ruth?
Yeah, I completely agree. I just think it's such an important part of the puzzle. There are lots of elements to it, but thanks for that.
Yeah, and thanks, Ruth. I'm going to take chair's prerogative, Chris, and ask one quick question before you have to dash. I think and by the way, I agree with all your points. I really love the fact you talk about we need to redefine what we mean by capacity. It's not just beds. I think that's absolutely right. I think particularly in an era of virtual wards. Your point on the scale of change appetites, I mean, we could probably do a session just on that in its own right, but this point about the change model being crucial. As the Edge Network, we're doing a lot of work on that. And I suppose my point would be, it comes back to the culture point, but it must be broader than health. The change model is about that integration piece rather than just health in itself as a delivery aspect. But my question is going to be, following on from Ruth, I think, going back to this prevention, Wanless type of agenda. I get your point on the funding issue. This is not the time for the NHS itself to be asking for more money, at least not publicly, and it's not politically astute of us to do so. But if we're going to change the conversation to one of prevention, then do we also need to have a debate about what the NHS in itself is actually responsible for, and therefore what it's not for? And is there an argument to be made which the NHS can support rather than be at the centre of, that funding is required on health, prevention, well-being related interventions that don't necessarily mean that funding is driven back into the NHS, but it actually goes towards powering up those wider determinants piece. Because I do think that we need to decouple in a nation's psyche the notion that the NHS is responsible for a citizen's health. But we can't do that if we're the ones constantly asking for the funding as a sickness centre.
No, I completely agree, Richard. I think you put it really, really well, which effectively is that, the obvious place to start is where you started, which is what are the determinants of health? And we actually know that, medical treatment is responsible for about 10, 15% of an individual's health. Actually, it's about stable employment, good housing, leisure, education. There's a whole bunch of kind of things that we absolutely diet, exercise, and couldn't agree with you more that we need a national mission to basically that covers the whole of our society to basically work on how we improve and enable people to look after their own health and well-being. And the idea, exactly as you say, that the NHS is the only, or indeed actually the most important method of kind of doing this is I think we're nowhere near as well developed as we need to be to recognise it needs the status of a national mission, and we're kind of part of that. But actually, and that's where I do think the link across to local government, which does have some of these responsibilities, it's got formal responsibility for public health, but I do think there is the opportunity there on a local level to really start to exploit that link with local government to really push this agenda forward.
Yeah. Chris, I know it's a busy day for you, so on behalf of the team, thank you so much for spending the time with us. Appreciate it always, and good to see you, and hopefully see you soon.
Good to see you, Richard. Thank you, everybody.
Thanks, Chris. Great, we'll move on to our last speaker for today. So Anita is another regular at this event and has been working with the team for 7 years to deliver this session. Anita's Director of Research and the REAL Centre, that's the Research and Economic Analysis for the Long Term at the Health Foundation, and she's also Honorary Professor in the College of Social Sciences at the Health Services Management Centre at the University of Birmingham. I know personally from listening to Anita last year that she's got the ability to make even the gloomiest predictions for the outlook for public services sound as if there may be possibilities and opportunities ahead. No pressure, Anita. And as always, there's time for questions following the presentation, so please do continue to use the chat box for your comments. Anita, over to you.
Thanks very much. I'm actually going to go very quickly through the financials, and then I'm going to focus on 3 issues that pick up some of the points that have been made by previous speakers and hopefully provide a bit more colour and context to some of the things that we're going to have to think about, particularly in the move to integrated care systems and boards. So the first thing is just to clarify where we sit on the money. Which is always useful. So since we last had this meeting, we've had a spending review that set out NHS funding up to 24-25. So slightly complicated chart, because in the world of COVID, everything is a bit complicated. So the purple line there was what, before COVID, we were expecting to happen to NHS funding through the long-term plan. And this is billions of pounds for the day-to-day running costs of NHS in England, adjusted for inflation at the time. And as you see, it was due to rise by the famed sort of 20+ billion pounds. The red line shows what then the extra funding that had to be provided for COVID itself. Yeah, actually still a bit of uncertainty about precisely how much that is. I don't think all of it has been spent in 21-22. And so then what I've done with the dotted green line, sorry, I've got the builders in, moved house, I closed the door. What I've done with the dotted green line then is take out the COVID costs. Yeah, so probably the it was actually difficult to spend money on core services in 2020. That's picked up a bit, but we are obviously finding still it's difficult to recover as a whole. What's planned going forward now then is obviously we lose a lot of that COVID funding, but the government is planning now to spend more on the NHS for the rest of this Parliament than it was in the long-term plan. Yeah, obviously quite a bit of that is coming now from the levy, which starts next month and is focused on the elective recovery. So there's about £10 billion potentially for elective recovery. Next slide, please. The other thing, which is one of those credit where credit's due moments, is this chart, which I've talked to you about before actually, shows how much of our GDP we spend on healthcare capital. And I've said now for a long time, that we've significantly and substantially fallen behind. And this is important because capital investment is typically really critical to productivity improvement, because capital investment often is investment in things which allow you to shift the way you use your staff and allows you to change potentially then the number of staff you need. So low capital investment obviously affects quality. We also know that if you've not got well-maintained buildings, they're often more expensive as well. And we've got the green agenda and the need to get to net zero, which will almost certainly have significant capital consequences. So we've been below the OECD average on health spending as a share of GDP for at least a decade. And actually we saw that fall essentially as we funded and bailed out day-to-day services from capital. Government is committed now to an increase in capital investment that will see us track the OECD average. That's good, but there's that backlog of underinvestment, which is the difference, if you like, between the red and the blue lines for a decade, and we're not above the blue line going forward. So this is better, but still leave us with significant issues. Next slide, please. The other thing, which just to emphasise the points that have been made throughout about what a challenging position social care is in. So we've had a go at kind of estimating what social care funding might look like going forward based on OBR, economic forecasts, government kind of broad spending expectations. And what we do here is index all of this back to 2010-11. And as you can see, the red line shows what's happened to spending in real terms as a whole. And so it was pre-pandemic, we just got back to social care spending being where it was in 2010. But obviously we've got a bigger population, and most importantly, the population has aged. So in the yellow line, I then look at, well, how does spend per head compare? And in the green line, how does spend per head when you just for age structure, how does that compare? And back pre-pandemic, when you've age-adjusted spend per head, still about 12% below where we were in 10-11. And even with some of the extra funding that was talked about early on going into social care, social care is faced with the prospect for the rest of this Parliament of spending per head and spending per age-adjusted per head still being below 2010-11. So that's 15 years, where the amount of money essentially available per person, once you adjust for age as well, being lower, which obviously I think explains so much of the challenge. Next slide, please. One of the things that people have talked about is the need to move from an illness service to a genuinely health service. And obviously a huge part of ICB's agenda is going to be population health. And the public health grant is not being cut anymore, but remains below, again, that 15-16 peak. So, structurally in our health and care system, we're spending more on day-to-day running costs in the NHS in the illness bit, less on social care, less on public health, still less on capital than we were, back in 2010. That's an unbalanced pattern of spending if given the ambitions that we've got. Next slide, please. And if you look at what's actually happened then to specific areas public health spending through that time, since 15-16. Stopping smoking services cut by a third, yeah. Drug and alcohol, and I think this is really important given the context of post-pandemic recovery, where we've seen substance abuse in terms of alcohol, problem alcohol use increase, down by 17%. Sexual health services down as well. Youth drug and alcohol down. All these really critical services having been cut very substantially. Next slide, please. And when we look then at the spending review, health increases above 3%. I mean, actually, outside the NHS, austerity is over in the sense that there aren't further cuts. But spending for unprotected parts of government, that's not health, that's not the direct schools budget, not some of defence, yeah, will still be a fifth lower in 24-25 than it was back in 2010. Yeah, so other public services still facing huge challenges, and local government having to rely on council tax revenue, and the living standards outlook looking really, really difficult. Yeah, so universal care taper being improved, but the £20 uplift has gone. Benefits not being uprated now by the emerging levels of inflation, and to address the issues around energy bills. So people hitting their incomes, and other public services still not well resourced to meet the challenge. Next slide, please. And after the spring statement last week, where we are in this is, so spending review, which I just talked about, had planned for day-to-day NHS spending, but to increase by broadly the historic average, around 3.7% a year. That compares to 21-22. Now, actually spending in 21-22 is slightly lower on COVID than they were thinking. So when you just for that, it looks like the plans in the future are a bit more growth, about 4.1%, but then inflation's tracking higher. So, I mean, where we are coming out of the spring statement and all the moving around that's going on is, broadly speaking, back where we were expecting to be in the spring, where we've got sort of historic increases in funding. Now, I mean, that's about double the rate of increase of the last decade, so it's good. But as Chris said, it's nothing like the sort of 6% a year increases that we had when we last tried to really transform services and recover and deliver acceptable waiting times. Next slide, please. So I'm going to focus, I think, in that context on three things, which I think are emerging now as really important things for us to think about over the next few years. I'm going to talk about efficiency, I'm going to talk about capacity, and I'm going to talk about pay, as I think issues which are going to be dominant things. So the week before the spring statement, Chancellor doubled the NHS's efficiency target. So the target for through this period was 1.1% a year, which is in fact above the historic average, which is 0.9% a year. And certainly pre-COVID, the productivity improvement has started to dip very significantly. So this looks a major stretch. Yeah. So that green, the historic average, blue was what we were aiming for in the long-term plan. The new target is the red. Yeah, so it's a massive increase in the efficiency ask of the NHS. Next slide, please. But alongside that, what I want to talk about then is where that efficiency is going to come from, and the link in particular with capacity and our model of care. Because through this next decade, we've got population growth, as you'd expect, about 6%. It's reckoned to be. We know we've got the aging of the population with the baby boomers rising. So the population 65 plus grows by a quarter in this decade that we're in. Yeah. So we're going to have to pivot our NHS and social care services very fast to cope with a quarter more over 65s than we had back in 2018. but the expected number of people dying each year is up by a third. And death is really important. Next slide, please. Because of pattern utilisation at end-of-life care. So we're facing a decade now where the ageing of the population and the baby boomers that we've talked about for so long are actually really having a significant impact on our service. And we're doing that against a backdrop of bed supply having decreased substantially in the past 30 years. That's one of the ways that we got some of the efficiency improvements that we've needed to do to deliver, you know, just under 1% a year. And as you can see, obviously, before this century, a lot of those bed reductions came from mental health and long stay. But then we have also seen significant reductions in general and acute beds. And it's the general and acute that I'm going to focus on now. Next slide, please. Bed capacity in the UK and England is actually really very low by international comparisons. So this is acute hospital beds per 1,000 population. And as you can see, Sweden and Canada are countries that we have less than us, but most comparable countries in Europe would have more beds per 1,000 of population. Yeah. Next slide, please. Now, why does all this matter and why am I worrying about this so much? It is because we've got this pincer of the need to significantly improve the efficiency of care, take costs out, alongside the ageing of the population and a rising number of deaths. Yeah, and this is really important because if you look at this chart, this is the admission to hospital rates by age, and they absolutely rocket with the very elderly, and length of stay is much higher with the very elderly, as you see with that as well. And in fact, when we do further depth analysis, this is driven largely by emergency admissions. Yeah. So the very elderly in the end of life care, you're having more emergency, less elective. Next slide, please. So the way we've delivered efficiency historically is we've had admissions increasing, length of stay falling, and so our number of bed days has fallen. Yeah? But actually, in order to continue to pull that trick, we're going to have to run our system, we're going to have to do this at a much greater rate than we've done before, because we're entering this period of rapid aging and an escalation in the number of deaths. Next slide, please. But that's against a backdrop where we've already got acute bed occupancy at almost 90% and real questions about the resilience and impact on quality of that. And we know even before COVID, we weren't meeting A&E standards, we weren't meeting cancer targets, we weren't meeting elective targets, running our system this hot. And in COVID, you know, there is at least a serious question to be asked is, did this model that we were running leave us really exposed and mean that some of the wider impacts on health and care were greater than in countries that had more capacity, more resilience? Next slide, please. So our average length of stay has been falling fast over the last decade, by a day on average in the last 10 years. One of the fastest falls across the OECD. We have a really good story to tell in driving efficiency through our system. Next slide, please. But again, our length of stay now is amongst the lowest in the OECD. And critically, when you start to look at some of these one or two countries that have, say, lower length of stay, the Netherlands, or lower hospital beds, Sweden, they do that, but they do that by spending lots more on social care, on community health services. Yeah? So we're trying to have our cake and eat it once again, to have lower hospital care, but not invest in the out of hospital provision that might mean that actually you can deliver good quality here rather than just save money. Next slide, please. So the questions that I've got are, how are we going to deliver that efficiency gain against this context of changing population dynamics? Yeah, where is the efficiency going to come from? Is it more of the same, of further reductions in beds, in length of stay, working our system harder and harder, or is it something profoundly different? And if it's something profoundly different, where's that investment coming from, and where's the scalable model? Because if we look to recent attempts at integrated care to achieve hospital admissions, we've just done a report on the 5 of the vanguards. They did not reduce hospital admissions for at least 5 years, and they didn't always reduce hospital admissions, and the amount of reduction was often quite small. So we don't have some off-the-shelf model that's going to deliver the impact here. We're also going to be trying to achieve this against a backdrop that we've talked about of workforce shortages, but some very challenging picture on pay. Yeah. So what I've just looked at here is what impact the rising inflation will have on nurses in the NHS, on the value of their basic pay, assuming a 3% pay award. Yeah. So if we get 3% pay award with 5.5% inflation, which is obviously current level of inflation, that's over £800 reduction in living standards. If inflation rises to 8%, which is what the Bank of England forecast for consumer price index back in this spring, then actually that's a fall in nurses' living standards from their base pay of £1,714. That's a massive impact on people's life. Yeah, that's not do I now make my coffee and bring it in a flask instead of buying a Costa. Yeah, that's really, can I feed my kids, can I pay my rent territory, isn't it? Yeah. Next slide, please. So a huge impact this year with real questions next year. Next slide, please. Yeah. So I think we've got lots of the historic agenda that we've been trying to achieve for 20 years as obviously the context for us now. We've got a bit more money that we've seen in the past, but actually I think we've got some new big questions, if you like, to refocus on as well. Where's the efficiency coming from? What capacity do we need? And what sort of capacity and what model of care makes that capacity sustainable? And how are we going to deal with these substantial pay pressures for our staff? And if we don't deal with the pay, how are we going to retain them and manage them?
Anita, thank you very much for that. Really sobering, and clearly the theme for today is workforce pressure, whether we're talking about health, whether we're talking about social care, the impact or the vulnerability that our ability to deliver services for our patients has on our workforce at the moment is absolutely stark. As Anne-Marie's put in the chat there, please do pop your questions for Anita into the chat. Anita, I suppose let's start with workforce. That's where we started with John, and that's where we started with Chris. I mean, the real terms wage cuts that you just identified there, as you say, are only going to exacerbate the numbers of staff leaving. I asked Chris more or less the same question. I think I asked John more or less the same question. Yeah. What is the answer to our workforce challenge? Is it simply additional money, or are there other things we could or should be doing?
Yeah, so I mean, I think the pay environment, if the review bodies don't give a significant uplift, is important, not just for staff not joining or staff leaving, but I think we also need to think very heavily about the stress that lots of our staff are going to be facing in their lives, where their living standards are falling to this degree. And so I think one of the things that the NHS needs to think about, and we've put quite a lot of emphasis on this in COVID, we now need to think that stress is post-COVID is going to be, as if not a greater stressful experience for staff. What is the support and wellbeing package that is being put in place by NHS employers to help staff through incredibly challenging times? And if you think about this, they're going to come to work and be in a workplace where services are incredibly stretched. Patients are often very unhappy. Stories, social media is full of stories where people have dialed 999, elderly relative, elderly neighbour who's fallen over, ambulance is taking hours and hours and hours. People are arriving distraught and angry into services. People can't get prompt care. So work is going to be really intense, really fraught. We know that job satisfaction is a lot, and stress are a lot about locus of control, and it's about feeling you can deliver good quality. So that's going to be really, really tough for a long time. Added to that, large numbers of our staff, particularly at the average and lower income in Agenda for Change, are going to be having sleepless nights trying to work out how to pay the gas bill, the rent, buy their kids their shoes. And they're going to be more of them are going to be food bank users as well now going forward. So that is a pretty toxic mix, isn't it? So I think one of the things that boards need to think very hard about is what's the ongoing welfare service that is put in place and wellbeing service for staff through that incredibly challenging time, because these are the toughest times I think many people will have experienced. The squeeze on living standards, in some estimates, is bigger than the 1970s. Yeah, so I think that's something that I would really say, and there will be an absolute premium on employers who are really compassionate and really care for their staff. And so things like making extra shifts available straightforwardly, all that, giving people that flexibility, all that sort of stuff is really, really important as well. So people feel like, you know, if they need the extra cash, they can get it. Yeah. So we might see some of that flexibility debate also shift from the I want to work fewer hours to actually I desperately need extra hours, you know, because otherwise I can't pay my rent. Yeah. So we are going to need to think a lot. I think what's really important is that NHS leaders take the time to put themselves in the shoes, walk a mile in the shoes of the people that they are employing. And I don't know the answer. Yeah. Your staff know what they will need. Some of it is not in your gift, but some of it is. But if you don't know and you haven't asked and you haven't walked a mile in their shoes, then you can't begin actually to address those issues. Obviously, we're hoping that international recruitment will help. Being a good employer is really critical. Supporting people from, you know, the anchor institutions that you talked about at the beginning, looking very hard at how we can create good work for people. But this is going to be a really tight labour market. 500,000 people have left the labour market across the UK, typically people over 50, very many of whom doesn't look like it will be possible to entice back. So we have to pull every lever in the book. But, you know, if you're a really good employer, you stand a chance. If you're a bad employer, you stand no chance. Yeah,
simply put. Thank you, Anita. And I remember reading that free NHS parking for staff ends tomorrow, on top of the increase in fuel levy. Absolutely. And I think Juliet put in the chat about she's hearing about fuel loans be given now to staff on lower bands in order to be able to allow them to get them to work. Yeah. And then, of course, as Fiona points out, the huge issues in patient safety as a result of a workforce. And that point you made about we may see a shift from I want to work flexibly to I want to work as many hours as possible. That in itself is not a positive environment, is it?
No.
You know, there's a responsibility on employers to know that employers are working safely as well.
Yeah.
Are there any positives?
So I mean, I do think there are a couple of so I think a couple of things that I would say which are positives. In the I think even 5 years ago, we just took I mean, fundamentally as a system, we took our people for granted. Yeah. And I think there is a kind of change there. I think this is a step up moment to really say these are the toughest times our staff will have experienced. You know, it's our moment to step up and be there for them. I mean, I think it'd be really interesting to see what the leadership review kind of comes out with. But I mean, actually, I think, you know, what is the leadership challenge now? You know, I mean, I think it is stepping up to be there and for staff and understand that. And the link to patient safety is really, really important and really well made. I think the second opportunity is that actually, I mean, I just don't see how we meet the efficiency challenge by the more of the same. Yeah. So I don't think more, and we've known more of the same wasn't really right for a long time. Yeah. But actually more of the same is probably just about doable. Whereas actually, I think if we try and meet this challenge with the more of the same strategy, we actually, it's not going to work. The big difference then is that actually what we've been trying to do to date with integrated care, frankly, doesn't touch the sides, yeah, of what's needed. So rolling out a few more of things that look like vanguards, yeah, organising ourselves to integrated care boards and all of that, setting some targets for emergency admissions, it ain't going to work, yeah. It has not touched the sides. So again, I think, you know, we've got a bit of a choice, you know, as we set up integrated care systems now, yeah, what actually we're going to be focused on. You know, time is not on our side. We've got to get stuck in to the substantial task of actually redefining the model, yeah. And if people are spending ages on governance, can you please look in the mirror and think about what's its chances of delivering? Obviously, the NHS has to be properly governed. But if you are a NED, yeah, if you are in a leadership role, look at your diary. How much of your week is on the governance structures? How much is on the new models of care and the people who are going to staff that? And just say to yourself, is that balance right? And if it isn't, how are you going to get the focus on the stuff that will actually get us through?
Yeah, absolutely. Well said. And it feels to me that if I was fortunate enough to be running an ICB board, as well as starting each meeting by listening to the patient experience, I think we should now start each meeting by listening to the staff experience. And as you say, how do you commit the time as a leader to be able to walk in people's shoes, to understand that actually sometimes even just getting to the work front door is the success of the day, you know? Yeah. Okay. Brilliant. Thank you, Anita. I'm going to bring John back in. John, hopefully you're able to just pop your camera on, and we will bring this session to a close with just some final reflections. Hi, John, and Steve's there as well. Brilliant. So, John, I'm going to come to you in a second. I mean, I love these sessions. I really love doing last year's as well. There's so much richness and wisdom from our speakers, but I can't help but be ending today's session feeling a little bit, I suppose, if not disheartened, but just recognizing that you know, we scaled a peak in COVID, it feels like, only to get to the top and look up and find that there's an even harder, even a higher peak. And maybe some of our support team who got us there have now kind of gone off to do other things, and we're expected to just get on with the job and keep climbing. It's a hugely important time to be resilient in health and care, isn't it? But everything we've heard from yourself and from Anita and from Chris points to workforce being the absolute key opportunity or vulnerability as to whether we're going to get to where we need to get to with both our short-term but our longer-term ambitions to sustain, but also to transform care. I mean, having listened to Anita, John, have you got any reflections on I suppose your perspective from what you brought?
I think the first thing I'd want to say, Richard, I really like doing these sessions because I learned so much from Chris and Anita, as well as yourself, actually. That's not just diminish your presentation, but what Anita and Chris are able to say about what's happening in the NHS and put it in a context, historical context, I find enormously valuable. So I'm sure others will feel the same. I'm not sure I can say very much more, Richard, to what I said earlier on workforce. I just think it's an incredibly difficult problem. And I think my worry is we aren't really having a debate about it publicly in terms, I mean, the people on this call are all having a debate about workforce, but it doesn't feel to me there's a lot of national conversation that involves the government about workforce going on at the moment. There is, if you look at some of the comments, specifically in adult social care, there's a presumption that things like charging reform and the fair cost for care will implicitly address the workforce issue. Well, I'm afraid it won't. There are some good things, ideas around, and we need to build on those. But we have to come back to the scale of the vacancies that exist in both parts of the sector. The worries there are about staff being worn out and burnt out and leaving and moving on. These are actually new issues. I mean, when I was at DAS in Oxfordshire, and I was working closely with NHS College, one of the big issues there was the future of primary care, because they had a primary care profile in which most GPs were quite mature and were likely to retire in the near future. Now, I don't know what's happened since then about addressing that, and hopefully they've been able to make progress. But the issue about how do we address these old issues, it just feels to some extent we're not, for some reason, we haven't got a national conversation going on about that. And I think that's a question for all of us to think about how we can help stimulate that conversation. That's not to undermine the efforts that Anita's making and Chris are making, but actually it's how do we change the nature of the conversation? Because one of the points I wanted to make, you asked for free comments. I wanted to say a little bit about capacity, because it seems to me that's a big theme as well. Workforce obviously determines capacity. For me, there's three issues really around. One is capacity, whether the capacity is in the right place, which was a point that Anita was making, international comparisons, which is interesting. And of course I would say that, wouldn't I? More resources in adult social care. But actually there is a really big issue about if you put more resources in earlier on, do you then reduce the amount you have to spend at the more intensive end? The second thing is about resilience, and Chris made a big point about that in his speech about the resilience of staff. I would want to add to that the tribute to staff across the sector, and actually also how well in many areas health and social care worked during COVID. I think there's some really good examples of excellent performance there. But the real problem is if you rely on resilience, what happens when the resilience disappears? And that's the worry. That goes back to the workforce issue. The other thing is, and I think this is again an issue about how do we create a public debate. I think there's a huge mismatch between the public's expectations and the capacity we can deliver. It's noticeable the people have featured to the latest satisfaction levels about the NHS, and they are horrifying. I can see why had NHS colleagues are worried about it, but actually, you look at the public satisfaction with social care, it's incredibly low. Now, to some extent, I've always taken the view that's because most members of the public are.
Oh, John, you just seem to slip yourself on mute for a second.
Sorry about that. So the point I was making is satisfaction levels of social care are actually even lower. And whilst I was saying, to some extent, you could say that's an issue about lack of knowledge. The fact is, we've got expectations around there which we're not meeting. And we either have got to do something about changing what we do, which I think we must do, but also there's a public debate about the public as a whole, and what their expectations are about this and what they need to do themselves to help manage their own health and social care needs, and about lifestyles and all those sorts of issues that are around for us to consider.
Thanks, John. And Anita, any final reflections?
I think one thing that I would add to this in terms of, I think there's something interesting about the integration debate that's struck me about, that's really been stimulated by COVID, is where people have died has changed in COVID. Yeah, many fewer hospital deaths, but also how people have a good death is really important to people, but also actually is really important in terms of getting this use of resources right. And coming out of COVID has been a shift to how we've been doing that. Think a lot about hospices. I don't think we think enough about the important role that, for example, residential care plays as a sort of tier below the hospice, place for people to die well, and really thinking through and managing what support people need in the home. But if we're going to think about some of the capacity and some of the integration, I'd encourage people to have a bit of a think in particular about end of life care. It's obviously incredibly important from a quality point of view, but actually it's really important in terms of our capacity And where the integration doesn't happen properly there and isn't well planned, it just consumes huge amount of resources that are lose-lose resources, with families and individuals having a dreadful experience of being pushed from pillar to post, and large amounts of spend.
Yeah, thanks, Anita. And for me, just to conclude my thoughts, I mean, I found it really fascinating, 3 hours or so, but 3 things for me. Workforce is obviously the biggest threat to the sustainability of our services, both for health and social care. How do we have a societal conversation about how much we value our social care and healthcare staff, and are we prepared to pay for them? The second point for me is, what is the NHS for? Can we shift our thinking, our perspectives from the NHS being responsible for citizens' health to an investment in the wider social determinants of health, and have a national debate about the expectations on the NHS to deliver health rather than healthcare? And the third thing for me is, from what I've heard today, and the solutions that people are seeking, this is not about invention. The future is already here. It's just not evenly distributed. We need to be able to better steal with pride. There is some fantastic work, fantastic work on workforce, fantastic work on innovation, fantastic work on transforming care delivery or integration happening everywhere in this country. We just need to be able to look out and steal with pride more, and that requires a fundamental shift in our culture to enable us to do that in a more humble fashion. So this isn't about sitting there, I think, and thinking about what can I invent to change the way that I deliver care. It's about thinking who's already doing this and where can I go and find out more about it, and then being humble enough to bring that in, adapt it, and make it happen. So that's all I wanted to say as well. So my thanks to Chris, who's obviously had to leave us, and to John, and to Anita, but I'll hand over to our MC, Steve, to finish us off in proper fashion. Steve.
Thank you, Richard. And again, I'd just like to echo thanks to yourself, to John, to Chris and Anita. Fantastic, sobering, thought-provoking presentations and discussion. So on behalf of everybody, a massive thank you. If I could just ask delegates, please, to complete the evaluation. This will help us in terms of future planning, and the link should be in the chat box. And also to remind you that you can now register for the next event on Thursday, May the 12th, Reframing Adult Social Care, and also the big NHS conversation sessions on the 11th and the 12th of May. And again, those links will be in the chat box. So thank you everybody for attendance. Look forward to seeing you at future events. And again, thank you very much, Richard, John, Chris and Anita.